R kappa, that was our case. So R kappa and L kappa, meaning anomalous right or left coronary arteries coming off of the pulmonary artery. It's a rare congenital anomaly. Usually we see it with the left coming off the PA, in which case it's also called Bland-White-Garland syndrome. And usually when you think about this, when an infant is born, the pulmonary artery pressures are high, so they're okay. But right after the PA pressures drop, that's when you're going to start to have problems. So about 90% of these infants actually die during the first year of life. But if they do survive, that's because there's extensive collaterals that are able to form. So there's the circulation between these collaterals is able to give blood to either the aberrant RCA or the LCA, but there is a steal phenomenon that occurs, and that's because the PA pressures are less than that coronary artery that's coming off of the pulmonary artery. So there's going to be flow reversal. So the oxygen in the left coronary artery or the right is going to be drained into the pulmonary artery, and then that's going to leave your left ventricular myocardium ischemic. So because of this steal, this is treated surgically. Either the coronary artery is reimplanted or it can be ligated and then bypassed with an arterial or venous graft. Next slide, please. So this is just a companion case. So now we see the same thing, but this is in L kappa. It's not a gated study, so it's a little bit messy, but this is the left coronary artery originating off of the pulmonary artery. So same idea, just different coronary. Next slide. This again is just a still shot sort of showing you the left coronary artery. You can see that big, large vessel on the left side of the screen is the aorta, and then on the right is the pulmonary artery. And that's, you can see connected to the right ventricle, and that's where the coronary artery is coming off of. Next slide. And then I love this because we talk about coronary steal, or we talk about this steal phenomenon, and I didn't really understand it until I actually saw this cath. So if you look here, we're injecting into the coronaries, but you can see that the only way that that LAD is filling, that large LAD in the back there, is actually filling through collaterals, and then the blood is actually going straight into the pulmonary artery from that coronary artery. So now you can actually see that the oxygenated blood from the left coronary is actually going into the pulmonary artery, which is kind of crazy. And then if we move on to the next slide, this is the same patient, and now we're injecting into the pulmonary artery. And now that you're injecting into the PA, it's really hard to see, but there's like a tiny little nubbin coming off of the right side of the pulmonary artery, and that's your coronary that's trying to fill, but it can't fill because the pressure, just because of the steal phenomenon. So it just really shows that the blood is from the coronary into the pulmonary artery. Next slide. Again, just some companion cases. You can see this is another L kappa, and the coronary arteries like really, really dilate, really very impressively because of the steal phenomenon. So all of them are going to be dilated, not just the anomalous connection, the anomalously connected coronary. Next slide, please, Kirsten. Another one. I guess we don't need this many. Okay, next slide. Okay, so this case, sorry, the animations aren't playing, but does anyone want to, do we have any trainees on who want to try and take the case? No. All right. I like this case because there's a chest x-ray. Sorry, the frontal isn't showing in this version, but if you look at the lateral chest x-ray, you can actually see that there are these coarse calcifications overlying the heart. I think had I not known the history, I probably would have thought that these were hilar nodes that were calcified, maybe sarcoid or other granulomatous disease. But this was a 16-year-old. In the history, we actually had the history that was a 16-year-old who was here for chest and cardiac workup because they had a history of Kawasaki's disease. And you can see in the image on the left that these are calcified coronary arteries in the areas where we're seeing the calcification on x-ray. Next slide, please. And then these are just the axials. You can see these are, peripherally calcified coronary artery aneurysms in this young patient who had a history of Kawasaki's disease. Next case. And then just to talk a bit about coronary artery aneurysms. So here's another patient who has a couple of coronary artery aneurysms. Some of them are calcified. You can see here, there's in the LAD, the circumflex, and the right coronary artery. So just for, especially for trainees on the call, I like to think about like what's causing these coronary arteries, these coronary artery aneurysms. I think that's important just to think about the different causes, especially for your boards. They like to ask that. Next slide, please. We'll go over it. So the size of, and also like what is a coronary artery aneurysm, right? So this one on the left is pretty obvious. This, you know, that LAD is huge. The one on the right, I think is a little bit less obvious, but certainly it is too large. So if it's about 1.5 times the diameter of the normal adjacent vessel, then we start to say aneurysm. Next slide, please. So what's the most common cause of coronary artery aneurysms in adults? Atherosclerosis. In children, it's going to be Kawasaki's. Again, the dilated vessel should be 1.5 times greater. A giant aneurysm, you can use that terminology when it's really large, about, you know, greater than 5 centimeters. And then the causes, right? So we already talked about Kawasaki's and atherosclerosis, but other types of vasculitis, Takayasu's or giant cell, we tend to think about them as affecting the larger vessels, the aorta, but they can also affect the coronaries. Marfan's disease, Loeys-Dietz, it could be a mycotic aneurysm, Behçet's disease, right? Some of you might remember seeing Behçet's on your boards. And then, of course, iatrogenic injury can cause these coronary artery aneurysms as well. Next slide, Kirsten. Oh, yeah, you have to click through a little. Sorry. Okay. I can keep going. Does anyone else also want to share a case? I have a whole bunch, but I'm happy to pause and let someone else share too. Or I can keep going. So this is a great case. Does anyone want to try and take it? What?
I have a question about the Kawasaki case.
Yeah.
Do you, in such situations, if you know the history and they asked for a CT coronary, do you give nitroglycerin to those patients?
That's a great. Sorry, go ahead.
I came across such a case, and the cardiologist felt that she is comfortable to give the patient nitro. I was surprised, but I wanted to know your input if you had a similar situation.
I actually have not come across that situation before. Maybe other people on the call have. That's my only known Kawasaki's, right? I've definitely had some cases of not necessarily pediatric patients, but younger patients with aneurysms, so we weren't really expecting them. This one was known, and the workup we did was actually just a regular chest CT. And then I think the patient actually ended up getting a cath at some point. But that's interesting about the nitro. I guess I would defer to our cardiologists.
Yes, I agree. Thank you. Thank you, Chair.
Yeah, sure. So here's our next case. Does anyone want to try and describe the findings? It's kind of interesting. There's a lot to look at. No one? Come on. Okay, I'll describe them. Okay, so this is an interesting case. It's a rare entity, but I've been in attending now for 4 years, and I've had 3 cases. So I don't know if we just happen to have like a hotbed of this diagnosis in New York City or something. But this is a patient who has pleural effusions, a pericardial effusion. And you'll notice when we're looking at their heart, you can actually see, if you see in the middle image, right by the right coronary artery, it's very narrowed and there's soft tissue surrounding it, which is a really interesting finding. I'll show you more of the coronaries in a minute, but then if you scroll down to their abdomen, you see what we call the hairy kidney sign. So there's this significant perinephric stranding bilaterally. This isn't a patient who has any acute illness in there with their kidneys. They don't have any AKI. There's nothing, that's not what this was done for. They've sort of had kidneys that looked like this for a while. So in a case like this, especially, hairy kidney sign, the differential diagnosis for that, certainly one thing we always think about is lymphoma. And lymphoma can also give you soft tissues surrounding your coronary arteries. So it's definitely something I would think about here. Another diagnosis is IgG4 related disease. That's something that we've seen. I don't know that it specifically gives you hairy kidneys, but it certainly can give you, retroperitoneal soft tissue and soft tissue surrounding your coronaries. And then the third thing is this diagnosis, which is Erdheim Chester disease. So we've seen a couple cases of it recently in New York. It's always interesting, and it's always kind of a fun diagnosis. I think I have a couple more slides on it. Kirsten, if you could just advance to the next one. So again, this is the same patient. They went on to have a PET CT, cardiac CT, and cardiac MR. And you can see, especially on the PET, like it's so, the FDG avidity in the region of the RCA is so focal and so nice. You can really see that there's, avidity, there's something going on here. It's not just, bland soft tissue. And you can see on the MPR image in the middle of the RCA that it's really soft tissue surrounding a very large portion of the RCA. This isn't just like a tiny focus of, non-calcified plaque. The kidneys you can see are avid on not just the collecting system, but the kidneys themselves due to the perinephric stranding. And then on cardiac MR, you can actually see that there is some uptake here in this delayed phase image in the pericardium, as well as you can see the pericardial effusion. Next slide, please. This is another case, right? Different patient, similar findings. Also just had this patient walk into the ER. I don't remember why they got a scan, but it was something like generic. They got a chest, abdomen, pelvis for it. Again, perinephric stranding, really impressive. It's not even, it's just soft tissue, perinephric soft tissue, these hairy kidneys. Pericardial, bilateral pleural effusions. There's some thickening to the pleura also anteriorly, which is a little bit unusual. Next slide, unusual for a run-of-the-mill pleural effusion. So Erdheim Chester disease is a multisystemic inflammatory non-Langerhans cell histiocytic neoplasm. I actually didn't realize it was considered a neoplasm, but it actually is considered to be neoplastic. Previously, it was considered to be inflammatory. I don't have any great cases showing the pulmonary findings, which are usually interlobular septal thickening and centrilobular nodular opacities. Usually we see pleural effusions, pericardial fluid, or thickening, and then you can see soft tissues encasing the coronaries in the right atrium. And then, of course, the hairy kidney sign, the perinephric soft tissue, is really impressive and can be really helpful. Again, all these things can be seen with different vasculitides, such as, including IgG4-related disease and lymphoma. Another thing that you can see with these Erdheim Chester patients is they get sclerosis in their femurs. So oftentimes a femur X-ray or femur MR can be done to sort of help with the diagnosis. Next slide, Kristen. This is just a differential case, right? So similar idea. Now you can see in the image all the way on the right, the RCA has this diffuse soft tissue surrounding it. The LAD and the circumflex and even the left main coronary have this like really diffuse soft tissue everywhere. So again, my differential would be, lymphoma, vasculitis, and next slide. This patient actually went on to rupture their circumflex. So here they have a big ruptured aneurysm. This patient did not do very well, but this is actually a case of IgG4 related disease. So looks sort of similar. This patient did not have a hairy kidney sign, but all those are on your differential. Lymphoma would have been on the differential also. Next slide, please. Can you click it one more time, Kirsten? Just so everyone, okay. So this, I don't know if there's any trainees on, this is sort of a fun case, something that I always tell all my residents is whenever you're scrolling through, especially on the axial, there should never be anything to the left of your aorta. If there's anything to the left of your aorta, it's either an abnormal lymph node or an abnormal vessel. In this case, we can see that it's an abnormal vessel. You can see in the MR image below that this is a vessel that has other vessels from the lungs draining into it. So this is an anomalous pulmonary vein. So this is a PAPVR, partial anomalous pulmonary venous return, returning into the vertical vein, which then drains into the brachiocephalic vein and then into the SVC. This is a really important diagnosis, right? Because this is a shunt. So instead of the pulmonary veins draining as they should be into the left atrium, they're now draining into the right circulation. So we can calculate the QPQS or the shunt fraction on MR, and oftentimes these patients need to go for surgery. Next slide, please, Kirsten. This is just for the differential. So here you can see on the left, there's a black blood sequence. There's a vessel there. And you can see on the right, you can see that this vessel comes all the way down and drains into the coronary sinus. So in this case, this is not a shunt, right? So this is a a left-sided SVC, a left-sided persistent SVC, or a duplicated SVC, which drains down into the coronary sinus. We see these not that infrequently. It's always exciting when they put like a line in one of these and you get excited on a chest x-ray and then you can figure out from prior imaging what it is. So this is just, if there's no branching vessels going into it and it's draining into the coronary sinus, then this is going to be just your persistent left SVC. Next slide. This is another one that I thought might be one of those, right? So I thought maybe this would be a persistent left SVC or something. This patient had a central catheter on the left placed. It does not cross midline like it should, which is concerning. So we recommended that they get a CT. Sorry, next slide, Kirsten. Thanks for being so good about the slides. So this is in fact just a really small vessel that we often see to the left of the aortic arch. This is the left superior intercostal vein. You don't really want to put a catheter in it because it's small, but oftentimes, we see these all the time. It's just a vein that helps drain sort of the left upper thorax. It's a normal anatomic finding. Next slide, please, Kirsten. This is just just showing the anatomy of what it is. People like to talk about it because on chest x-ray, there's a characteristic tiny little bump off of the aortic arch. You can see it there, that little beak. People call it the aortic nipple. That's why everyone likes to ask about it because it has such a ridiculous name. So that's your left superior intercostal vein. Next slide. Here's a companion case. It's hard to see. This patient has an endotracheal tube and then a bunch of lines on top of them, but there is a left central venous catheter that goes down. If I was going, on a regular day reading through a stack of 100 chest x-rays, I probably would have just said that this is in the mid SVC or distal SVC or something. But if you're on a good day, you'll notice that the trachea is actually to the right of the catheter. Which doesn't make any anatomic sense. So this patient actually ended up getting a chest CT. Next slide, please, Kirsten. So this was a carotid stick. This vessel this line went right into the aorta. So, sometimes when you have lines to the left that don't cross midline, they are in small venous or vascular anomalies, but sometimes they're actually not. So this is an important thing to think about. Next slide, please, Kirsten. So again, just same patient showing on the axial, as you can see it going right into the left common carotid into the aorta. It had to be removed in the OR and then stented actually, but the patient did okay. Next slide. Here's another case. This is sort of interesting. I've been reading a lot of these post-op Watchman cases. So usually when you put a Watchman into the left atrial appendage, right, we do a lot of pre-Watchman measurements. We make sure that we get the right size, and we don't see too many complications from them, or at least I haven't seen all that many. But every once in a while we get a case like this. And if you look at the image on the, I guess on the top left, you can see it best. You see the Watchman device, and the entire left atrial appendage should be completely thrombosed. There should be nothing in there, no contrast. And you can see that just adjacent to the Watchman, there's a little sort of streak of contrast that kind of goes around or almost through it. And you can see it in the short axis. So this is a peri-device leak, right? So it's leaking through. And there's different reasons why this can happen. Usually these are due to incomplete endothelialization, just because it hasn't really been in there long enough. So usually I give these about 3 months. I'll say, oh, it's probably just incomplete endothelialization. If it's been more than 3 months, then I'll actually call a peri-device leak. Next slide, please, Kirsten. Every time I have one of these, I open up this article from Radiographics from 2021. It's a really good article. It's just the nomenclature is like a little bit confusing. There's peri-device leaks, there's transfabric leaks, where it actually goes like through the fabric itself of the Watchman. So I really like this, this article. But basically after 45 days, you shouldn't see any contrast in there. I guess maybe I'm a little bit more liberal. I say, we say usually 3 months we give it. And then apparently there's an increased risk of thrombus formation with the peri-device leak, but there's no significant correlation between leaks and thromboembolic events, which is really interesting. But I think this image here in the center really shows a nice peri-device leak. You can see like the contrast going around the Watchman device itself. Next slide. on that topic of left atrial appendage. This is a case from a recent case I just had, actually. A patient came in with aphasia, right arm weakness. Neuroradiologist said there's a stroke on the left, as we can see from the brain MRI. And then they astutely noticed on the scout image that there's a nodule in the left upper lobe. And so they recommended to get a chest CT with contrast. Next slide, please. So the nodule is a really, it was a fun nodule to find, right? So I opened up this CT. This patient has a very large nodule in the left upper lobe. I think it was over 2 centimeters. And there's this central popcorn or coarse calcification. So this is compatible with a benign hematoma, which is great for the patient. And then the other thing that we saw was their left atrial appendage had a huge thrombus in it, which obviously in this patient with an acute stroke, they did not know about this. The patient actually had an echo that had already been performed that day, and the echo just said no LV thrombus, and that was it. It didn't mention anything about the left atrial appendage. Obviously, sometimes it can be hard to see it, but you can see in the middle image, I think you can see it best. It's just really nice where you can see that there's slow flow at the tip. And then below the slow flow, you can actually see the thrombus itself. So, I think this patient, they were really confused what to do with them because they had a stroke, they had a normal TEE, they were going to move on to a bubble study. They were, but luckily they happened to have gotten this, regular contrast enhanced chest CT, and we ended up finding this for them. So the patient, they were sort of able to figure out a little bit more about what was going on with the patient. Next slide, Kristen. This is another case. I like this case. One of my colleagues who does not do chest imaging sent me a case like this and said, what is going on? I have no history for this patient. They're an outpatient. It looks like there's a big pseudoaneurysm off of the left ventricle, but they're walking around. This was done for something else. What is this? So I said, do you have a non-con? And they said, no. So I said, well, it's an interesting case, but this is just mitral annular calcification. It's just confusing when you don't have a non-con on board. Next slide, please, Kirsten. This is a different patient, but similar idea. So it's always in the same spot, right? Mitral annular calcification. It's a common mass seen on echo. If you have a non-con, it's a really easy diagnosis to make. We don't really think too much about it. But when you see these on other modalities, like a contrast enhanced CT or an MR, it can be, I think, really confusing. I actually find the MRIs, the findings of MAC, really the most interesting. So if you look at them, you can see that it's iso-intense to myocardium on SSFP. That's the bottom left image. If you have a T1 or T2, then you can, it's usually hypo-intense. And then on delayed enhancement, there should be no central enhancement at all. You can see in the images on the right, on the bottom. Sometimes there's peripheral enhancement just because there's a fibrous cap, but there should be no central enhancement. So this is not a mass. It's always going to be, right in the location of your mitral valve annulus, of your mitral annulus. It oftentimes can look like a ball, right? Especially if there's a case of like caseous necrosis where you have that central liquefaction within the MAC itself. But I think it's always nice to see it on different modalities. Next slide, Kirsten. Here's just another case. So this is a different patient, but same idea, right? So you see it on the contrast enhanced CT on the right. You can see it's iso-intense to muscle without any real enhancement, maybe some enhancement in the periphery here on the bottom right image over there, but really on the SSFPs, it's really dark, really iso-intense to muscle. And then I think if you click one more time, maybe we'll get a non-con for the same patient, Kirsten. Yeah, so, it's easy when you have a non-con. And, always look, sometimes you can see it on an x-ray. It's pretty simple to see, like the nice C shape or ball shape. That can be helpful too. Next slide.
There we go.
This was also a recent case. This was a outside abdominal CT. It was called on an abdominal CT, which I think is really great. I think it's a really, really good call. I mean, in retrospect, obviously it's a huge, very important finding, but it's really hard when you don't get the entire thing in the field of view. So you can see here, there's an outpouching off of the right ventricle. It's sort of, there's a very narrow neck. You can see that narrow neck. You can kind of appreciate it, I think, in the top two still images. And so, this is a RV pseudoaneurysm. So this patient was actually transferred to our institution to have surgery. So which they did. They had a successful surgery. They removed the pseudoaneurysm, but it's just a really interesting finding, especially the fact that it was found on an abdominal CT. Next slide, please. Oh, this was the op note. It said pseudoaneurysm was trimmed off circumferentially. It had the appearance of thin-walled scar tissue. The RV apical defect was closed with sutures. So a nice outcome for the patient. Next slide. This is just a differential, right? So we talk about pseudoaneurysms and then we talk about aneurysms. So usually when you're dealing with the left ventricle, we think more about true aneurysms, especially at the apex. Usually they're going to have a wide neck, not a narrow neck like the one that we saw. In these cases, in this patient, this is due to a prior LAD infarct. So they have this very large LV apical aneurysm. The left ventricle is not working well. And you could see in the bottom right, there's delayed enhancement, transmural infarction throughout the entire LV apex. So just to sort of think about the differences between pseudo and true aneurysms. Also, if you think about LV apex, that would be more usual to see a true aneurysm, whereas other places like the inferior wall of the LV or in the RV, that would be more usually associated with a pseudoaneurysm.